Olá, sou Celso Arrais. Primeiro queria agradecer a hematologo pelo convite, estar aqui e dividir esse espaço com a doutora Ana Sureda. We'll switch from English from now on, so thank you, Anna, for being here. First, we are going to discuss on this session, on the lymphoma and CLL session that was just presented here at the SBTMO Society meeting. I'd like to ask you if you want to comment on in the first presentation was on mantle cell lymphoma, if you want to comment on the highlights.
Sure. So thank you very much, Celso. So as Celso has said, we have to switch to English. I come from Barcelona, Spain, and I also want to thank the organizers and, of course, the sponsor for allowing me to participate in this podcast. So I think that the first presentation was really very good one. We were discussing about the role of autologous and allogeneic stem cell transplantation in patients with mantle cell lymphoma. I think that the first aspect that we need to take into consideration nowadays is that we have to individualize the treatment strategy for these patients. Now talking about first-line treatment and, of course, the role of autotransplant. So with the data that we have with new prospective clinical trials, the universal role of autologous stem cell transplantation, at least for young patients that were transplant eligible, is not as clear as it was in the past. With the data coming from the triangle trial, we know that we can eventually skip autologous stem cell transplant and substitute autotransplant by ibrutinib, both in the chemotherapy strategy and in the maintenance strategy. I think that this is important, not only because of the treatment itself, but because probably it's going to impact in the way that we are treating these patients when they relapse or they progress after first-line treatment. In spite of that, we still need to understand that probably there are patients with high-risk disease that could eventually benefit from a consolidation with an autologous stem cell transplantation, and also these data come indirectly from the data coming from the triangle trial. And we also have to think about the potential role of allotransplant. Of course, allotransplant is not devoted to first-line treatment strategy, but there are patients with relapsed refractory disease that, in spite of the new treatments that we have nowadays, if they are young enough, if they have high-risk disease, and if they understand the potential toxicities associated with allogeneic stem cell transplantation, they have to be considered for that.
Can you just comment on for these very high-risk patients in Brazil, in which we don't have CAR-T yet? So do you think there's still a role for autologous or an allo? I mean, would be not to expose patients to too much toxicity. Some of our colleagues, they just wonder if an allo would be possibly used not in the first line, but at least in the first relapse. And if still there's a role for autologous, if that patient we know will relapse shortly after autologous. So how do you see that? It's just knowing your opinions.
Yeah, I think that, of course, all these decision-making process depend very much on the availability of new treatment strategies or different treatment strategies in each one of the regions. And I think that probably the role of allogeneic stem cell transplant is very much modified by the possibility to use CAR-T that, of course, as we will be discussing later on, are clearly competing for a similar population of patients. I don't think that we have a lot of data, for instance, to consider allogeneic or to take into consideration allotransplant as first consolidation strategy, even for high-risk patients. But it's true that there are patients that have specific mutations that make them chemorefractory from the very beginning. So one may think that why we are going to offer chemotherapy and eventually high-dose chemotherapy with an autologous rescue to a patient that we know it's not going to respond correctly. And I think that on the basis of this concept, one option could be to select a specific high-risk population of patients, young patients with no comorbidities that might eventually benefit from an allo, even as first consolidation strategies. And on the contrary, considering every single patient candidate for an autologous stem cell transplantation might not be the correct way to go. talking about the reality in Brazil, where CAR T cells, autologous CAR T cells, are not available, at least for the time being. I think that allo represents probably the only curative treatment option that a patient with relapsed refractory disease have. So this is one strategy that I would definitively consider for young patients with high-risk disease.
Okay, great. The second session when was on CLL.
Exactly.
Yeah.
So now it's my turn. Let's go to the second session. And of course, you presented, well, first of all, I think that a very nice overview on the treatment landscape of patients with CLL, with relapsed refractory CLL, which of course has been a very evolving landscape in the last few years, and also try to rejuvenating or to put into perspective the role of cellular therapy, basically allogeneic stem cell transplantation in these patients. So if you can comment a little bit on that, and of course also the specificities that you have in Brazil, taking into consideration the portfolio of new treatment strategies that you have.
Yes, great. In Brazil, it's really a challenge because we know 80% of the population is in the public sector, in which there is no second line yet. So that looks really striking to anyone living in a better scenario than ours. But in Brazil, it's really true that we do chemoimmunotherapy first line and we have to do chemoimmunotherapy second line because there's nothing else available. At the same time, the session was to discuss what we have in the literature and what we can apply, especially in the private sector and even in the public sector, when we can send patients to trials. That's the best way to go, because these patients in the public, they will not have access to these drugs, but they can be included in clinical trials, which is always a good thing. But what we have revealed is that, based on what we have now in the era of all these novel agents, things have changed, because we no longer need to send all these patients to transplant as we did in the past, especially 17p deleted patients in the past. We used to do alemtuzumab, high-dose methylprednisolone, and then send them to transplant. Now with all these new agents, especially BTK inhibitors and BCL2 inhibitors, these patients can remain a long time in remission, and they can be even going to further second and third lines with these novel agents, our agents. So it's much safer than it was in the past, and then still they are not exposed to clonal selection, which was a very bad thing in the past, especially in TP53 mutated patients, when chemotherapy usually used to increase the number of clonal cells in a large number. These patients had a very bad relapse, and it was usually chemorefractory and very aggressive. Now we don't see that any longer. So many of centers such as yours, they say they they no longer do allo transplant for several years, and we can say the same about our private sector. We usually don't, or we don't need very few and selected patients. We can say every 3 or 4 years we might have a candidate. In the public, we still do need to transplant several patients because of what we have just discussed. So I think now, based on what we have, patients are sent or are referred to CAR Ts or transplant if they have been refractory to at least BTK inhibitors and BCL2 inhibitors, and even after non-covalent inhibitors, if that is available. So these patients are very selected. They might be refractory to several lines, and sometimes that takes many years to achieve that, and patients sometimes are too old when they achieve that triple refractoriness, so they are no longer candidates for transplant. So the mix of everything makes these patients rare. If you wanna now, we can go to your next or your last presentation, which was based on CAR T, and if you wanna comment on how you think CAR Ts have changed the paradigms of both mantle cell and CLL, if you think and we need to struggle and to fight as much as we can to get these drugs, we can call CAR T drugs or just a cellular therapy, but available for more patients, so we don't expose them to, because we know that the bad thing about allo is a very high risk of non-relapse mortality that was in the past around 20-25%, now probably close to 10%, but it's still high, much higher than CAR T. So if we won't expose these patients to such a high risk if a CAR T was more available. So
So I think that if we talk about mantle cell and CLL, I think that CAR-Ts have basically changed the treatment landscape in mantle cell lymphoma. I don't think that this is the case still for CLL, at least in Europe. As I have mentioned in the presentation, we don't have any construct available outside prospective clinical trials or eventually academic constructs. So for CLL, I think that the indication is significantly more restrictive. I think that for mantle cell lymphoma, yes, CAR-Ts have changed the treatment landscape in the relapse refractory setting. And the data basically coming from patients included in SUMA-2, which was the pivotal trial that gave the indication to brexucabtagene. I think that they have been already quite consolidated in terms of long-term follow-up. So basically, my reading from the trial and what we have in real world is, first of all, that the curves don't show a plateau. The curves from SUMA-2 don't show a plateau. So I am not 100% convinced that even this very effective treatment strategy, because the complete remission rate and overall response rate is very high, are a curative treatment strategy for these patients. So that's one thing to take into consideration. The other thing is that a non-relapse mortality or the toxicity, at least for Brexucel, which is the construct where we have more experience, is not negligible. So non-relapse mortality is between 9 and 10%, which of course is still higher than for allogeneic stem cell transplant. Because I have to say that for whatever reason, non-relapse mortality in mantle cell lymphoma patients being treated with an allo transplant seems to be higher than for diffuse large B-cell lymphoma and, of course, for indolent lymphomas. So we cannot forget about this non-relapse mortality, basically in mantle cell lymphoma being treated with Brexu, which is basically related to infections, not to CRS or neurological events, but basically to infections. And probably the situation is going to change when Lysocell, now I'm talking with my European hat, when Lysocell is being approved by EMA, because the toxicity profile is significantly better, and mantle cell lymphoma patients, they represent a very old population of patients normally. So I think that if you look at the guidelines, if you have CAR-T cells available, they go before allogeneic stem cell transplant. After having said that, allotransplant is still a curative treatment strategy for these patients, and in areas around the world where CAR-Ts are not available, of course, I think that for a young patient with relapse refractory disease, and of course nowadays we have the BTK inhibitors, we have non-covalent inhibitors, and then we have several prospective clinical trials, I would basically go for an allotransplant. But CAR-Ts have modified the way that we are treating the relapse refractory setting, and we have to wait for the results of, at least that I know of, a randomized prospective clinical trial that it's looking at the high-risk population of patients at the time of diagnosis, and maybe CAR-T cells can bring additional benefit in this specific setting. I think that for CLL, the situation is a little bit different. So it's quite an heterogeneous disease from an evolution and long-term follow-up. We have really very effective drugs that probably are not curative, but they are able to keep these patients alive for a significantly longer period of time. The median age of patients with CLL is also quite high, and probably because T-cell fitness is significantly more impaired in patients with CLL than in other B lymphoid malignancies. The results that we have with CAR-Ts are not as brilliant, as spectacular as we have seen, for instance, with diffuse large B-cell lymphoma or indolent lymphoma, or even with mantle cell lymphoma. and CAR Ts are associated also with their own toxicity. Probably with the different constructs that have been tested, the one that has more probabilities to go into the market, and it's already in the market in US, is Lysocell. That for those patients that achieve a complete remission and that achieve an MRD negative status, the results in terms of duration of response, PFS, and overall survival are really very good, but still few data. Of course, in Europe we don't have data. There are not real world data that are able to let's say to move this information forward. And I think that probably we need to elaborate a little bit more on how the CAR T-cell constructs are being used in CLL, because the results are not as good as one would have liked.
Okay, just so as to conclude, in Brazil, we know that even when CAR Ts like Lysocell or Brexocell become available, it will be for a very short percentage of the population, because for now, what we have learned from Tisacell and Axicell, it's still very limited. So very few patients have access. It's still the insurances that won't pay. So that's still very complicated. So I wanted just to be sure that you agree with me that allo is not dead in these two diseases, and these patients, once CAR T is as we always say, it's available but not something available but not for everyone. So if you still would tell the audience, those who usually don't send patients to allo, if allo still has a role in these two diseases. And
I think that at least for the time being, even with the new drugs, even with CAR T-cell, autologous CAR T-cells, I think that allo remains the only curative treatment strategy for both mantle cell lymphoma and for CLL. And we have data that have already been published with patients that have a very long-term follow-up, and the curves present a plateau. So it's a curative treatment strategy. Of course, patients need to be very well selected.
Informed of the risk.
Of course, they have to be very well informed. We have been able to significantly reduce non-relapse mortality for both mantle cell and CLL patients that are candidates for an allograft. And of course, I think that at the end of the day, how you position allogeneic stem cell transplantation and in which type of patients you are going to perform an allo is quite dependent on the accessibility to these new treatment strategies. And it's not only if, let's say, if they are approved, yes or no, by the regulatory agencies, how expensive they are, but we have to talk about accessibility, which is also quite heterogeneous depending on the different countries and the different and the different areas. So I think that allotransplant, even if we are not performing it very frequently in any of these diseases, remains a completely standard of care treatment approach for these patients, and is a curative treatment strategy.
Okay, great. Thank you very much again for being here and for your insights. They are always very informative. So thank you again.
Thank you very much, Celso. Thank you.